Hello, this is a webinar presented by Sussex Ehlers-Danlos and Hypermobility Group, SEDS, based in Sussex, and positively provides specific funding for activities, therapies and advocates strongly in all areas that affect us throughout Sussex and beyond. I am Jane Green, Chair and Founder of SEDS, and today I'm delighted to say we have Dr. Jessica Eccles, who trained in medicine, completing a BA in the history and philosophy of science, sparking a keen interest in philosophy of mind and brain-body interactions, and since graduation from medical school has pursued a combined academic clinical path at Brighton and Sussex Medical School. She's an Honorary Consultant in Liaison Psychiatry. Dr. Eccles is currently working on an Academy of Medical Sciences grant to explore neural connectivity in hypermobility using leading-edge brain imaging techniques. She also happens to be our patron. I will now be passing over to Dr. Eccles, and I will ask some questions at the end from our members. Thank you.
My name, as Jane said, is Jessica Eccles, and you can follow me if you're on Twitter at Bendy Brain. It's not a particularly imaginative title, but it sort of says, it does what it says on the tin. As Jane explained, I'm something called a clinical academic, which means I split my time between clinical practice and between research. And pretty much all, not completely all, but all of my research is to do with the link between the brain and the body. And most of it is related to hypermobility one way or another. I'm also in the last couple of years, I became a consultant psychiatrist, and I'm a liaison psychiatrist, which is all to do with the body and the brain. And I have two clinical interests. One is something called immunopsychiatry, which is about the overlap between the immune system and mental health. And the other is neurodevelopmental disorders. So my regular clinical work is in the adult ADHD, autism and Tourette service in Sussex. And I see patients who've been referred to that service in Brighton and also East Sussex. So you see there's lots of logos. These are some of the people that have kindly given me money to pursue my research. And without them and all of the patients who have kindly taken part, I wouldn't have anything to tell you, really. So I've called this Hypermobility, and it's really lab to clinic, a journey to personalized medicine. It's really a foray into how I got interested in the subject and the things that we've been finding out. And with the hope, the overarching hope of all of this work is that this will inform personalized treatments for hypermobile people in the future. So whether they be drug treatments or non-drug treatments, but so that basically people can recognize hypermobility and treat its many extra-articular manifestations. So extra-articular means beyond the joints. So I'm not normally one for personal stories. Oh, I've got to work out how to move my slides on. I'm not one normally for personal stories, but I'm going to give you a little foray into a couple of things that happened to me as a medical student that were quite important in terms of pursuing this career later on. And I'll be talking about how my work at BSMS has evolved and implications for the future. And of course, I'm happy to take questions. I don't know how the chat's being moderated. I won't be looking at the chat whilst I'm talking because that's just too many things to do all at once and will scramble my brain. But if you have interesting questions, please do put them in the chat and I'll endeavour to answer them. You can always, if you want, and you don't have a chance to ask the question or if something comes up later, please do either tweet me at bendybrain or you can send me an email at j.eccles@bsms.ac.uk. So I ended up at clinical medical school, so that's the last 3 years, in Oxford. Oh, this picture hasn't enlarged in the way that I'd hoped. It was much bigger earlier when I looked at it. I take it everyone in the audience can see what this picture represents. So anyway, I'm a fourth year medical student in doing an orthopedics rotation, which I'm unusually interested in because I myself have a condition called developmental dysplasia, which is where your hip socket's not formed properly and leads to arthritis. And I knew when I was a medical student that I would be staring down the barrel of a hip replacement. So I was quite keen on attending theatre, but I'd often feel quite dizzy and faint in theatre. And anyway, one day I was on a ward round, and one of the, not an orthopedic surgeon, but an orthopedic physician, which I'd never even heard of before, came up to me at the end of ward round and said, "You've got swayback knees. Why don't you come and see me in clinic?" So I was like, okay. And he diagnosed me with what was then called hypermobility syndrome, which, to be honest, I really hadn't heard of before. And I was, at the time, I was finding it quite hard walking around the hospital, all the stairs, all of the constant ward rounds. I was in a lot of pain. And he said, "I know what you need. You need a pain rehabilitation program." And I was like, "What's one of them?" And medical school, as you can imagine, there's not much holidays or time off. It was arranged that instead of doing a time that I would have picked in something like anesthetics or something, that I would spend 3 weeks as an outpatient on a functional restoration program. And at the time, I was just interested in learning how to live and manage with pain. But I actually think, looking back on it, in terms of my line of work, that it's been some of the most useful 3 weeks that I ever spent in terms of learning about living with pain, about pacing, and the things that I learned on that program, I often tell to patients to this day. So that was me back in 2004. And then we're going to fast forward a few years of difficulties walking around the hospital and various things until I decided to pursue a career in psychiatry at Brighton and Sussex Medical School. And when I came to Brighton and Sussex Medical School, I just knew I wanted to do psychiatric research. I wasn't at all sure what it was going to be. And I met with my supervisor, a man called Professor Hugo Critchley. And he said to me, "Have you ever heard of something called hypermobility?" And I said, "Yes, that's quite interesting. Actually, I'm hypermobile." And he said, "Well, I want you to find all the people who've been in the brain scanner in the last year." At the time, the brain scanner had only been around for about 18 months. "And I want you to find out if they're hypermobile." So that led me into doing quite a bit of reading about hypermobility. And although this comes from a little bit later, and I don't have to tell you all about all of the things that occur in hypermobility, there was a very interesting article about hypermobility published in the British Medical Journal. And it prompted quite a bit of response. It was by, I've forgotten her name, Ross, who I think is a physiotherapist. No, I'm not sure. Someone called Ross and obviously Rodney Graham. And this article was explaining about all of the different manifestations of hypermobility. Admittedly, he didn't talk about anxiety at all. So I wrote a little letter to the BMJ talking about the relationship between hypermobility and anxiety. And another doctor wrote back and said, "I used to think I was a bit of a croc from a long line of crocs, But when I read Ross and Graham's article on joint hypermobility, some pennies started to drop. My party trick has been to touch my thumbs to the volar aspects of my wrist and to voluntarily sublux my first metacarpophalangeal joints. The article does not include that as a criterion, but all the women in my family can do that. I have double jointed elbows and knees, which hyperextend, and a neurologist once noted I had an extraordinarily flexible lumbar spine. So far, so bendy. Then I read about the other manifestations and thought they were probably true too, since I'd already had a uterine prolapse repair at the age of 37. I thought that was it, but the letters published this week really started me thinking again. Firstly, Mola Holly writes about precipitate delivery, postpartum hemorrhage and incontinence, tick. Then about subluxation of joints in labour, tick. I was delivered of my third child in the McRoberts position, which I now realise was a mistake. It resulted in me not being able to independently move my legs for a week. Then Dixon et al. Wrote of urinary stress incontinence in nullips, that's people who haven't had children. My difficulties were always attributed to post-delivery damage, but in truth they predated that. I was just too embarrassed to seek help. Lastly, and not insignificantly, Eccles and al. Write of panic and anxiety as manifestations of joint hypermobility. Certain of the women in my family have taken anxiolytics for as long as I can remember. I have never taken any, but I suffer from anxiety which manifests in chronic insomnia and bad dreams which I live with, managing them with exercise and good sleep hygiene. So am I just a bit of a crock? I now think maybe not. So I'm sure that this idea of a light bulb moment of hypermobility unifying people's experiences is something that many of us can relate to. And this is why I found this condition so fascinating, is that it had the potential to unite and explain so many different problems in different parts of the body. So, where's this? So no, this is just a summary of the letter. We don't need to worry about it. But I'm not going to bore you because I'm sure you know it all. But hypermobility is not at all just in the joints. It is in the skin. It is everywhere in the body because connective tissue is everywhere in the body. So we're just going to have a whistle-stop tour of some of the known associations of hypermobility, which I'm sure some of you are familiar with. So, oh no, this is a picture of hypermobility, which we all know that there are problems with this particular scale. There's lots of important joints like hips, shoulders, ankles that are not depicted by the Brighton scale, but it does at least provide a starting point for researchers, doctors, nurses, and physiotherapists to look to objectively assess for hypermobility. Oh no, I've got confused. The slides that I thought were coming are coming later. We all know that hypermobility can both be an asset and a liability and is much more common in certain professions. So it's almost a prerequisite for being a ballet dancer, a gymnast, professional musician. I spend quite a bit of time during the summer when it's not locked down, looking at tennis players playing Wimbledon and looking at their hypermobile joints and spot diagnosing them. But we know that connective tissue is everywhere in the body. There's actually not very much in the brain, but there is a bit. There are lots and lots of conditions associated with hypermobility. So asthma, Chiari malformation. We're going to talk more about postural tachycardia syndrome, carpal tunnel syndrome, developmental coordination disorder, also known as dyspraxia, various different headaches, migraines, pain amplification, gastro problems, constipation, inflammatory bowel disease, problems with incontinence, irritable bowel disease, hiatus hernia, and then an inflammatory condition called eosinophilic esophagitis. There are some genitourinary problems, irritable bladder, pelvic organ prolapse, urinary stress incontinence, cardiovascular problems, mitral valve prolapse, and of course, conditions that are sometimes hard to understand and hard to treat, things like chronic fatigue syndrome, chronic pain syndrome, fibromyalgia, and of course, the line of work that I became particularly interested in, anxiety. So, when I started work on looking at joint hypermobility and anxiety in late 2009, there had been quite a lot published. The first real associations were in the 90s, and we knew that from the Spanish group that includes Antonio Balbena, that they took 100 people with panic and with panic symptoms and 100 people without, and they found that 70% of the people with panic symptoms were hypermobile compared to only 10% of the people without panic symptoms. So that was really a very marked difference. Sorry, I get very thirsty on Zooms. So they also did, so that's been, that finding of increased rates of anxiety and hypermobility has been replicated over and over. And it's not just anxiety diagnosis, it's anxiety scales, it's in clinical populations, it's in healthy populations. But what was interesting is there's a little bit of research that suggests that hypermobile people are more likely to have habits that might be to do with coping with anxiety. So these are in some ways quite fun articles. So the same Spanish group did an article about hypermobility, intensity of fear, and compensatory chocolate consumption, suggesting that higher rates of chocolate consumption in hypermobile people is mediated by anxiety. So sounds fairly benign, I suppose, chocolate consumption, but they also found increased tobacco and alcohol use amongst women with anxiety, and postulated that this increased alcohol and tobacco use in those with hypermobility, and postulated that that was a way perhaps to cope with anxiety. And then there was a big drama in the 2000s where a Spanish group thought that they had found a gene that expressly linked anxiety to hypermobility. Unfortunately, that has never been replicated, but it still remains a source of interest in terms of better understanding the genetics of hypermobility and anxiety disorder, or hypermobility in general. So we know, I'm just going to have to move my speaker view because I can't see this, but we know, so this is something called a meta-analysis, which is putting together all sorts of papers. Now I know from having read a lot of the original papers that hypermobility is very poorly defined in the literature. So some people are using Spanish scales, some people are using the Bayton scale, some people are using JHS, and now, of course, since then, we have the distinction between HSD and HEDS, but that wasn't apparent at this point. So I prefer to use the term hypermobility as a catch-all phrase. And this reports benign joint hypermobility syndrome, but I know that that was not actually what was being looked at in most of these papers. Most of these papers were just was generalized joint laxity, high Bayton scales. So they found 4,000 participants, and they found that hypermobile people had a 4 times likelihood of experiencing anxiety, 4 times depression, it's nearly 7 times panic than people without hypermobility. So this was really something that was worth pursuing, because how do you get from having flexible joints to being more likely to have a panic attack? It doesn't necessarily make a huge amount of sense. So we all know, because we've all experienced symptoms of panic or we've heard about them, that there's things like chest pain, discomfort, palpitations, feeling of your heart racing, sweating, trembling or shaking, sensations of shortness of breath, feeling that you can't breathe. These are symptoms of anxiety, but these are also symptoms, these are manifestations of an overactive fight or fright nervous system. Oh, there's more of them. Nausea, feeling dizzy, unsteady, lightheaded or faint. Unreality, depersonalization, fear of losing control or going insane, sense of impending doom, numbness or tingling, chills or hot flushes. So as I said, how do we get from one of these to the other? And that was where the imaging study that my boss, Professor Hugo Critchley, asked me to do, provided a small piece of possible evidence. So what we did is we took 72 healthy volunteers who had been through the brain scanner, and we divided them into two groups, hypermobile and not hypermobile, using a very loose definition of hypermobility. And we were looking at something called structural brain imaging, which is about brain structure. We also looked at anxiety level and levels of interoceptive sensibility. And this is what we found. Some of you may have seen this picture before, but these parts of the brain are a very exciting part of the brain for a young researcher to find a difference in. These are on both sides of the brain. Those yellow blobs are in something called the amygdala. And the amygdala is part of the brain that is responsible for fear processing. It's also responsible for emotional memory, and it's very tightly coupled to control of the involuntary nervous system. And what was also interesting is that we found that the higher your Brighton score, the smaller a part of your right superior temporal lobe was. And what's interesting is those differences had previously been reported in autism. At the time, there was no formal work linking autism expressly to hypermobility. There were just several case studies. And we also found that the more with the higher your Brighton score, the smaller a part of your brain that is responsible for where you are in space. And that's the sense of proprioception. And we know that hypermobility is associated with dyspraxia and developmental coordination disorder. So hypermobility is not just the joints. We've found a brain region that's implicated in fear and emotional memory. And this is possibly a distinct type of disorder which may lead to individual treatment approaches. So we also know, so this is from an article about hypermobility, that there are some common clues that suggest joint hypermobility that are important. And the reason why I had highlighted this was the poor ball catching and handwriting skills may be related to the dyspraxia. And obviously this prompted an interest in me in tiring easily compared with peers, the idea of fatigue and also pain, which is something that I came to revisit a little while later. So I've talked about proprioception. We know that there is a link between dyspraxia and joint hypermobility syndrome. This is a paper that was showing similar brain imaging differences in autism as to what we found in hypermobility. And this also sparked an interest in this idea of interoception, which is the sense of what's happening inside your body. And what we found in that study was that hypermobile people seem to be particularly keenly aware of lots and lots of sensations happening in the body. And this is something that we we began to study further in later studies. Oh, I'm trying to move my slides on. So this is just some questions about from an interoception questionnaire. I won't go into it, but it's things like my mouth being dry, watering or tearing of my eyes, my skin itching, noises associated with my digestion. Patients, we found that patients with hypermobility had a higher sensitivity to bodily sensations. We also, this is going back to this paper before, they knowing about this idea of autonomic dysfunction, such as orthostatic intolerance, dizziness or faintness, or postural tachycardia syndrome, and also irritable bowel syndrome. So I remember when I was a medical student, see there's quite a bit of, when I was a medical student, I had to write an essay in neuroscience on, do we run from the bear because we're afraid, or are we afraid because we run? Now, the typical idea is that it is that we run away because we're afraid. But what my supervisor was teaching me and showing me evidence for was actually it's the body's responses to fear that may, in fact, make us feel fearful in themselves. So he had done these brain imaging studies where they showed people pictures in the brain scanner and they played them what they thought was their heart rate. And sometimes they played them their normal heart rate, and sometimes they played them an accelerated heart rate. And people rated even neutral faces, neutral images, as more intense if they thought their heart was beating faster. So the idea is that the involuntary nervous system can set as a context setter for our emotions. Just as if you're lying in bed and you kind of hear something out the window, if your heart's beating faster, that will probably feel more fearful than if it isn't. So this is where postural tachycardia syndrome comes in. So I'm sure some of you in the audience may have a diagnosis of postural tachycardia syndrome, or may wonder if you have it yourself. But this is where you have an overactive autonomic nervous system and your heart rate goes up by 30 beats per minute when you go from lying to standing, and it's diagnosed by a tilt test. We know that the symptoms are very similar to those of anxiety. I'm not saying it's the same as anxiety, but it's a context in which things may seem more fearful. And there are lots of shared symptoms. We know that POT is probably, these figures have now been updated, that probably about 75% of hypermobile people experience some form of orthostatic intolerance. That's either your heart rate going up when you stand up or your blood pressure going down. And that almost all people who experience orthostatic intolerance have some degree of hypermobility. And we think that even quite conservative studies in America suggest that at least a third satisfy HEDS diagnostic criteria and further satisfy HSD criteria. I'm going to have to speed up a bit. So we wrote a paper about the interrelation between joint hypermobility, anxiety, and postural tachycardia syndrome. And then we did a study to try and get into a bit more into the mechanisms of how hypermobility might be linked to anxiety. So I'm just going to skim through this because actually this is taking longer than I thought to get through these slides. We looked at nearly 400 psychiatric patients in Sussex Partnership. And we found that almost all psychiatric diagnoses, there were overrepresentations of hypermobility, but that was particularly high in things like anxiety, ADHD, autism, and eating disorder. We've subsequently done more work on eating disorder and have more patients than are included in that slide. And what you can see here, the men are in red, and the women are in blue, that there were really high rates of hypermobility in ADHD. So women with ADHD, kind of 75%, women with eating disorder, 70%, autism spectrum disorder, well, autism spectrum condition, 70%. Okay, so what you can see here is this is in the general psychiatric population, that if you are hypermobile, you have many more autonomic symptoms than if you're not hypermobile, and that this is particularly prominent for women. We can see that that degree of autonomic symptoms correlates with how hypermobile you are and is different in men or women. This is symptoms, not signs. And you could see in a subgroup of patients with ADHD and autism how your Brighton scale tracks with the autonomic dysfunction. And then this is the same sort of thing, but this is particularly an anxiety disorder. You can see how much higher autonomic symptoms are compared if you're not anxious, and how that this is really driven by a relationship between hypermobility and anxiety. So almost 5 times as many symptoms if you're hypermobile and anxious compared to if you're not anxious and not hypermobile. And then we also look to see what happened to people's heart rates when they stood up. And if you aren't anxious, people's heart rates went up by about 16 beats per minute. But if you are anxious, about 16 beats per minute. But if you weren't anxious, by about 8. And again, this is massively driven by hypermobile heart rates going up by about 20 beats per minute. And if you are anxious and non-anxious, non-hypermobile heart rates going up by about 7 beats per minute. So this, I'm not going to dwell too much on this because this is the science behind a study that's currently going on at the moment. But what we find is that the relationship between the autonomic dysfunction and how that's perceived in the body mediates activity in a part of the brain that's involved in anxiety, the insula, and also anxiety level. So we think that this might be an explanation, and this is something that we're trying to put into practice with our remote treatment trial of a novel treatment for anxiety and hypermobility at the moment. So this is a model of how hypermobility might be linked to anxiety through several different mechanisms. But basically a relationship between the brain and the body that's all about differences in the involuntary nervous system, differences in how we perceive sensations in our body. I forgot to say, because normally I'd make this interactive and ask questions, but obviously we can't do this in COVID, but that one of the reasons why you might get postural tachycardia syndrome if you are hypermobile is because your blood has pooled in your feet and isn't pumping it back to the heart. That's the impaired vasoconstriction. So to maintain blood flow to the brain, when you go from lying to standing, your heart rate has to go up. So I'm just going to talk a little bit about, about the work that I do now clinically, which is neurodevelopmental work. So these neurodevelopmental conditions or neurodiversity includes dyscalculia, dyslexia, ADHD, Tourette syndrome, autism, dyspraxia. And what this slide tries to demonstrate is normally people perceive of these things as disorders, but actually, and in fact, you know, ADHD is called attention deficit hyperactivity disorder. But actually, having a brain that's wired up this way can be really important for creativity, detail processing, memory, innovative thinking. So although it might be thought of as a disorder, it's actually a fascinating and interesting way of being in the world. But a lot of arrows were pointing towards a link between hypermobility and neurodiversity. So when I was first looking into this, this was just some case studies and also the observations that we found in the brain that were similar. So we systematically, but then whilst I was doing this research, we were pipped to the post, really, and you can't beat someone looking at the entire population of a country. So they found in Sweden that having EDS or hypermobility syndrome was associated with a 7 times risk of autism. Interestingly, nearly 3 times risk of bipolar disorder, and a 6 times risk of ADHD. And there are many common links between joint hypermobility and neurodiversity. So things like anxiety, dyspraxia. Lots of neurodiverse people experience abnormalities of the autonomic nervous system, just as hypermobile people do. Very high rates of pain. And in fact, we pre-printed an article about pain in neurodiversity only very recently. Some colleagues in France have proposed a model that links hypermobility specifically to neurodevelopmental conditions through body-mind connections. So this is a French colleague called Carolina Bieza-Velasco. This is just another way of showing the data that we found in Sussex, that being hypermobile having autism gave you a, oh, sorry, I'm getting confused here. So if you were hypermobile, you had a 4 times risk of having autism, 4 times risk of having ADHD, and a 7 times risk of having Tourette syndrome compared to if you were not. And in this group, that they had significantly higher symptoms of autonomic dysfunction than controls, and that the amount of autonomic dysfunction tracked with the Brighton score of how hypermobile you were. And that in the neurodiverse group, there was significantly more pain symptoms than controls. And this is just reiterating the link with dyspraxia. So we also looked at 33 patients with eating disorder and found that 70% of them had what used to be called joint hypermobility syndrome, and that this was linked to something called systematizing, which is one of the features of autism. So what I'm hoping to demonstrate, that it's really important if you're someone like me working in an autism, ADHD and Tourette syndrome clinic, is if you see a patient with one of those conditions, to think, oh, might they have hypermobility? Because hypermobility is really common. And in fact, most of the patients we see in our clinic do in fact have hypermobility if you look for it. But then the reverse is true. So should we have a low threshold for thinking about autism and ADHD and Tourette syndrome in people with hypermobility? I think so. Also, we should really be asking people about autonomic symptoms and referring them on for appropriate investigation if we suspect them. So I'm just going to, so I've talked a bit about anxiety and neurodiversity. I want to tell you a little bit about some findings to do with chronic pain and chronic fatigue. So a few years ago, myself and Professor Kevin Davis applied for some money to look at mechanisms of pain and fatigue and in fibromyalgia. And what we decided to do was look at people who have both pain and fatigue, people who have mainly pain, people who have mainly fatigue, and people who had no pain or fatigue. And we wanted to see what happened to their pain and fatigue when they went on a tilt table. And we were also doing blood tests and all sorts of things like that. and a whole lot of autonomic function tests. We put them in the brain scanner, and we wanted to see if their brains and bodies were particularly sensitive to inflammation. So people came in, were scanned after having a placebo injection and also after having a typhoid vaccination injection, which mildly increases levels of inflammation. And lo and behold, what did we find? We found that this is the patients who entered the study. About a third of them had a diagnosis of fibromyalgia. A third of them had a diagnosis of ME/CFS, and about a third of them had a diagnosis of both. What we found is they almost all met diagnostic criteria for both fibromyalgia and for ME/CFS, but that really interestingly, just over 80% of them met criteria for joint hypermobility syndrome, and nearly 20% of them met criteria for HEDS. So there seems to be an important link between hypermobility, chronic pain and fatigue. And we're also just writing up research that suggests that link explains your vulnerability to pain through an autonomic challenge or an inflammatory challenge. But what was interesting is of those patients with fibromyalgia and ME/CFS, they have lots of symptoms. They've often seen lots of doctors or nurses or physiotherapists. Only about a fifth of them had been told that they were hypermobile before we examined them. And we also found that their pain and fatigue symptoms correlated with below, so within the normal range, levels of inflammation in the blood. And what was interesting is in the patients with pain and fatigue is that their Brighton score, so not their current Brighton score, but their historical Brighton score, so what they were previously able to do rather than what they're able to do now, correlated with almost all of the pain and fatigue measurements. So ME/CFS and fibromyalgia appear to be more commonly comorbid than previously anticipated and appear associated with variant connective tissue, and there is a direct association with symptoms. So this is almost, I'm only 5 minutes overrun. So I wanted to show you a flavour of some of the work that has been going on. There is other work. I have a grant that's unfortunately been paused because of COVID, where we're looking at brain mechanisms, neural mechanisms of brain fog and how that might relate to abnormalities of the flight and fright nervous system. We've got an ongoing brain imaging study of hypermobility. And we also have our treatment trial of a novel non-drug treatment for anxiety in hypermobility. So I've probably spoken for long enough. I will say thank you to all of the participants, and I think there's been nearly 1,000 who have taken part in my various studies. And I really hope that we can raise the awareness of hypermobility in the medical community and beyond.
Great. Well, we are really delighted, and as you can see through the chat, they're a bit gobsmacked, actually. I think I was having a look. Some of the questions, and I think you might have answered them, but one family aren't here. They have hypermobility Ehlers-Danlos. They have 2 diagnosed children with autism or autistic, PDA, ADHD, exercise motive functioning problems, and a long family history of autism, genetic syndromes with Turner's, autism, and SEDS, and mental health problems. And they wanted to know how it was linked to hypermobility Ehlers-Danlos.
Well, that's really interesting, because I mean, I didn't go into it in a huge amount of depth but the explanation for why joint hypermobility might be linked to anxiety is quite straightforward in terms of, well, seemingly straightforward in terms of abnormalities of the flight or fright nervous system response, and the things about vasoconstriction, so the blood pooling in your feet and what might happen and how that might condition your brain to be on high alert and to be kind of more finely tuned to kind of threat and danger. Why hypermobility may be linked to autism and ADHD is a much more complicated question. I think that there isn't a straightforward, easy answer. I think that they are both developmental conditions. They are all developmental conditions. So they are essentially something to do with how the brain and the body develops, and that these things tend to develop together. But in terms of precise reasons why, that's actually very hard. Though there is a abnormality. It's not the only abnormality, but there is a gene that is different that's been identified as being important in POTS, which is also identified in ADHD, about how we transport adrenaline or noradrenaline in the body.
Gosh, so lots of research needed.
Absolutely, but I really can't overstate it in that in the clinic that I work, almost all the patients that we see, with not every single patient, but the vast majority of people we see, autistic patients, ADHD patients, Tourette syndrome patients, almost all of them are hypermobile or have hypermobile family members.
Yeah. So in the future, is the idea to find out more about it and therefore cure hypermobility syndromes?
I don't think, I mean, maybe I don't think that there is really a cure for hypermobility. I think the important thing is recognizing it, and doctors recognizing it, physiotherapists recognizing it, teachers recognizing it, everyone recognizing it and managing and supporting people with hypermobility appropriately. I don't think it's something that we need to get rid of in the population at all. I think it's something that needs to be recognized, and then we need to adapt around it.
Absolutely, and as you say, it has some strengths in some areas.
Absolutely. I mean, there are some pieces of music that can only be played by people who have, really wide octaves. So some pieces would want you to jump 10 notes, and that they can only be played by hypermobile people.
That was Paganini as well,
yeah,
wasn't it?
exactly.
I was so excited because I'm just finding my way through this, and there's one. Anyway, I've got another question. What are the links between Ehlers-Danlos and mastocytosis?
Well, this is something that I haven't really touched upon in this talk. Partly because it's actually really hard to do research into mast cell things, but we know that there seems to be a link between hypermobility, autonomic dysfunction, and overactivity of mast cells, which are important immune cells in the body that produce things like histamine. So we know that lots of hypermobile people seem to have unexplained allergies, or come out in hives or rashes, or have weird hay fever. And we think that this is related to mast cell activation syndrome. The problem with doing research into mast cell activation syndrome is that the chemicals or the substances in the blood and the urine are really hard to find. So I have put in a couple of grants, but it isn't, it's very hard to do something that you can count, which is kind of what people want in research, is for you to isolate something So in our current studies, in our most current studies, we are asking people about mast cell symptoms, but so we're just reporting that there is a high rate of mast cell symptoms. But what's good is a colleague of mine, Dr. Emma Reinhold, she wrote the wonderful EDS toolkit for GPs. And the thing is if you suspect that you may have mast cell activation syndrome, then some of the treatment is actually remarkably straightforward. So things like antihistamines. And for some people, they can make a huge impact to their lives, and I've seen it happen in terms of a dramatic impact, especially things like fatigue, and they're all interlinked. People talk about the trifecta, but apparently the three things of EDS or hypermobility, postural tachycardia syndrome, mast cell syndrome. Emma was telling me that instead of thinking that there are three things now, people are talking about a septad, which is 7 things. But we know that there are so many different things that are all interrelated.
We've got so many questions. I'm just trying to keep up, but I wanted to follow through. Like, that one of the things you said earlier. So I've done a little bit as well with Sussex, but the anxiety and the when the adrenaline shoots off, it has a really detrimental effect with mast cell. And I know I suffered a lot from it because we never had answers. And I remember I don't have a diagnosis, and a lot of members don't, but we get diagnosed with something like allergic rhinitis or
Yes.
something like that. But the management, as you say, works with the antihistamines most of the time. So it is management, isn't it?
It is management, and unfortunately, it is quite hard within the NHS in the UK to find a referral to a mast cell expert. So a lot of it is trial and error and simple managements like antihistamines or possibly a low histamine diet.
Yeah. So we will be talking about mast cell later on. It is a huge subject, I know. I just need to get through some of the other questions, but I think all the stories we've heard from members seem to be coming up at the same time. One person wants to know, they've got chronic PTSD and they wanted to know, and anxiety, if if psychotherapy is an important tool in managing PTSD and anxiety.
Yes. So I myself haven't done particular work in post-traumatic stress disorder, but I think that in my practice as a psychiatrist, we would say pretty much that we should always take a multidisciplinary approach, and that combining psychological therapies with self-management strategies and, where indicated, medication is really important to tackle something from all sides rather than just one angle.
Thank you. Migraines. My neurologist only says food, sleep and smoking are my issues and refers me to a pain clinic. I think that means watch her food and sleep and smoking. Is there anything else? She wants some answers.
I'm afraid I'm not a migraine specialist, but I have heard that certain medications can be helpful. Again, I'm not a specialist. Avoiding triggers is important, but also I think things like making sure that your zinc and magnesium are adequate are often found to be helpful.
This is quite a common one I come across with members. My children are hypermobile, but I'm told there's no such thing, and it's just getting very trendy for patients requesting a diagnosis.
Well, it depends on whether you think trendy and common are the same thing. We know that hypermobility is, we don't know the exact how common HEDS is, or even how common joint hypermobility syndrome was. But we know that 20% of the population have generalized joint laxity. So that is really common. And actually things like anxiety and irritable bowel and fibromyalgia, all of these things that are linked with joint hypermobility, even autism and ADHD, which are not uncommon, they're all common. So I don't find it surprising, but I think that some people, which is probably a totally valid point, think, well, if something's so common, how can it be responsible for so much? So I think it's important to take the right history, and it's perfectly possible to be hypermobile and not have all of these things. But if it's about connecting the dots, and as I know SEDS is all about think if you have issues, think connective tissue, and that's certainly how I would approach things.
Yes, it's not our saying, but I don't think it's attributed to anyone that I can find. Thank you. And also, of course, you know, back in the day, autism wasn't common, so it just shows that better diagnosis, it makes it more common. Would psychological support help gastroparesis?
I am not an expert in gastrointestinal disorder, but I did work for some time, not in gastroparesis, but in inflammatory bowel disease. And we ran a psychological support clinic for people with inflammatory bowel disease, and it improved their bowel symptoms. I think being open to any reputable avenue of treatment is important, but I couldn't possibly, I'm afraid gastroparesis is not my area of expertise at all. But we know that having any chronic illness, it will no doubt have an effect. A physical chronic illness will have an impact on your mental health. And if you're able to treat your mental health, that may make things in the body seem easier, and if you're able to treat things in the body, they may help things in the mind.
I think that sort of adds up myself, but yeah. Another question on the chat form: I already have diagnoses of anxiety and autistic traits. My GP has suggested full testing for autism, but I'm worried that having the diagnosis will affect the way I'm treated by medical professionals like the anxiety has. I think you should talk to me as well. Okay.
I think it's really important. I mean, we could have a huge debate. We could have a whole hour-long session on the relative merits of labeling. But it's important, if you are in work or education, to sometimes having a label that is correct obviously gives you protection. So it means that people have to make reasonable adjustments, that they can't fire you, or without going through various processes. And I think what I hear in clinic is that people find that an autism diagnosis, a bit like a hypermobility diagnosis, can be a real light bulb moment and really help them make sense of how they are in the world and the things that have happened to them. But obviously, if you're not keen on pursuing it, then I don't think the GP can make you. But for a lot of people do find quite a bit of solace and peace in a diagnosis, even if that takes some time to come to.
Yes, I think we're getting more and more adults looking for support. So luckily there's a new group starting for that as well. If you're interested, contact me. So I think, let me just have a look. We've done the psychotherapy one. I have, well, I'm not sure that Dr. Eccles can do this, but I have gastroparesis and I'm currently being managed with an NJ tube. They are looking at the possibility of a PEG-J. Is it possible that psychological support, I think we answered that, might not help that bit. So I think you
Well, I think it's important, as I said, if you have any chronic illness, to make sure that you're looked after from a mental health perspective.
Okay, a theme coming through is doctors not acknowledging things and dismissing us and our symptoms, and or we're told, and I know this comes through, bring a list of symptoms. Well, you come up with a great big file when you go along, bar COVID, and then they look away in horror. And it's connecting all those dots when you see different consultants.
Yes.
So I think it's a lot about how we manage it. And I know that's more maybe what we do and other charities do, but I think it's just having that belief is so important.
And I think I know that a lot of hypermobile people feel misunderstood and dismissed, and they're and I can completely see how that has come to be. But I suppose we're actually fairly early days in understanding things about hypermobility, and so much has changed just in the 10 years that I've been working in the field. I'm confident that within the next 15, there should be much better recognition. And as I said, it was only when I was at medical school in the early 2000s. It was I don't remember being taught hypermobility in the syllabus. It was only being approached by this random consultant to tell me that I knew anything about it. And I really don't remember learning much about fibromyalgia at medical school either, or MECFS. But these are all really important issues that doctors are facing all the time. I was doing some research for an article that Professor Kevin Davis and I are writing at the moment for an important medical journal. And things like pain and fatigue are some of the most common things presenting to GPs. So I think that the work of people like Dr. Reinhold to produce the EDS toolkit and to really improve lots and lots of doctors' recognition of hypermobility and related conditions and symptoms is absolutely massive, and will have a huge impact.
Someone says OCD. What is the link there, or is there one?
Well, that's interesting. So of all of the anxiety disorders, there really isn't much written about hypermobility and OCD compared to panic or generalized anxiety disorder. It would be really interesting to go into an OCD clinic and to have a really good look for hypermobility. But I suppose I see, and I'm not saying that the poster has autism or ADHD, but we see in our neurodevelopmental clinic that the neurodiversity, there is often a lot of obsessive compulsive behaviors, if not disorder, and that is another unifying theme.
Right, just to note that obviously not everybody will get to your clinic.
No, absolutely not.
Yeah, just the usual. If you actually mention MCAS in the referral letter, they automatically refuse it. We have to be very careful how it's worded.
Is that your question, Jane, or is that
it's a question from someone else? Sometimes if you mention it in the referral letter, I'm not quite sure that's number.
But I think the real difficulty is I mention it in letters to GPs all the time, and I haven't had particularly negative feedback from any of them. But I do know that the real problem is so what if I was saying to a GP, someone took part in my study, or I'm seeing someone in clinic who seems to have symptoms of MARCEL, I would just refer them directly to the EDS toolkit, because there is no one to refer them to in the NHS locally. So they wouldn't know whether to go to rheumatology or dermatology. And as far as I'm aware, in Sussex, at present, there are no clinicians, as far as I'm aware, who are particularly interested now that Professor Davis has retired.
Yeah, it's really unfortunate. And the one question I keep getting all the time is there one person that can look after me? And who do I see now to get a diagnosis and then be looked after forever? And that doesn't happen, but we're here. Just so we're going to wrap up soon, but another one is nutritional deficiencies, eating disorders, and diet.
Yes.
Yeah.
Yes. No, I think nutritional deficiencies are actually much more common in hypermobility than people think. And this is quite topical with COVID because there's some work suggesting that having low vitamin D is a risk factor for being hospitalized with COVID, for example. And I think it's always, I had this again, I'm not dwelling too much on my own story, but I've always thought, oh, it's good to maintain important nutrition, but I've always thought, oh, I'm a bit busy. And then last year I was doing some data analysis and leant very hard on my elbow, and I ended up in hospital with quite severe cellulitis from a infected bursitis. And I thought, oh, how could this happen so quickly? And it turned out that I was deficient in almost every vitamin and mineral, and that's probably why I developed such a nasty bursitis so quickly. And so I'm now taking multivitamins, and I think it is important to have a balanced diet. That's something that I struggle with. But if in doubt, there are cheap over-the-counter multivitamins, and as long as you don't overdose on too many multivitamins, it's not good to take excessive quantities of vitamins and minerals. Having a balanced diet or having a good supplement, I think, is really important, and it's important for brain health, for skin health, for bone health, and as we can see, it's also involved in the immune system and in everything that's unfolding about COVID, and maybe even long COVID as well.
Yeah, that's really interesting when vitamin D comes up in the, I think.
And I talked earlier as well about zinc and magnesium, and these are all supposed to be very helpful too.
Yeah, and magnesium bars and flakes and things.
Yes, that's the thing. Magnesium, it's quite hard to absorb it orally, so it's best to have it in a bath.
We've just had one point. Thank you. I have just had elbow surgery last week to remove damaged bursa. So they're going to watch their nutrition. So that's great. I'm really, really grateful. And we all are. I think we've got all the questions. And I'm really cognizant that we've gone over your time. And you've
no, that's all right. Providing people are still willing to listen, that's okay.
Oh, okay. We've got one question was on Tourette's. Is that like OCD, sort of not as strong a link, or what do you think?
Oh, what, Tourette syndrome and mobility? Oh yes. So I've just we've just published a paper, pre-printed a paper showing high rates of hypermobility in Tourette syndrome.
Oh, okay.
Yes. I'm sorry. I thought you meant is Tourette syndrome like OCD, and I was going to go into it.
No, sorry.
Okay.
It was What about I've got a question. There doesn't seem to be much knowledge about hypermobility in children in education.
Oh, I know. And this is something we've talked a little bit before about, Jane, isn't it? And it's definitely, there are so many ways that having hypermobility could impact on your education, from things like getting sore hands, handwriting, difficulties with pen grip, fatigue, ADHD, there are autism. There are so many ways in which it's important to recognise hypermobility in schools. And I think we and Jane and I have certainly talked about this offline before, about trying to improve awareness of teachers of looking for hypermobility. And that reminds me of some of the slides about things that you realize in young children, like they were talking about poor ball skills and bottom shuffling and things like that. We need the same sort of things, but for school. I mean, I remember I used to try and play the violin. I was really not very good at it. But one of the reasons why I was not good at it is holding my violin bow. My fingers just basically collapsed, which is why I can't to this day use chopsticks, because my fingers just can't do it.
And interestingly, I mean, I was a teacher and I can't do handwriting, and it was, I just can't. And you know, you have to go on the whiteboard or whatever, and you think of different adaptations you can do to get around it, or you ask someone else to do the handwriting that day for you, or and what about navigation skills? Does that come into it at all?
I think that comes into, I don't think I can think of a particular word for navigation, but we certainly in the neurodiverse world with the dyslexia, dyspraxia, dyscalculia, we talk to a lot of people who either find navigation very difficult or incredibly easy, and people who get their left and right mixed up, they all seem to go hand in hand.
Yeah, and a lot of my students used to be ambidextrous, so they had no dominant hand at all, which is quite difficult. I would just want to thank you again. Maybe my members can pass you more questions or contact you, as you said, and you'll put all your links at the end. And it's been brilliant. I'm really delighted. Thank you so much.
That's all right. And thank you to all of the audience. I wonder, just to indulge me, if you don't mind, because it's a very strange thing, talking into the ether and only looking at your own reflection in the computer screen. If any of you mind putting on your computer screens and just waving.